conference on something that started during COVID, but we're trying to keep going strong for an extended period. And today we're going to have a theme that is the second half of what we started this past Friday. If for those of you who turned in, talking about spinopelvic alignment and how it affects degenerative disease fusion. So we'll talk about some of the same studies, a little less depth on the study, but more detail into interesting cases and how we can apply the things that we learned in those studies to cases. And I always like to show some stuff I did right and some stuff I did wrong, because you always learn more from the ones you did wrong. So we are going to get started with one case presentation. Then I'll talk a little bit about understanding spinopelvic alignment for the degenerative disease surgeon. This is a talk that is, if you're very accustomed to measuring everybody and thinking through, you may find it a little bit on the basic side, but for those of you who aren't converts to the new religion in spine, it gives you a lot of, I think, a better understanding of why we're looking at the things we're looking at with a lot of data. And then we'll look at some more interesting cases from there. So we'll get started. Kayla, you can get started on the first case as soon as you are ready.
Okay, just one moment to bring it up.
Kayla's a PG3 resident with us right now. She's interested in being a spine surgeon and currently doing a great job on the spine rotation.
All right, so for our first case, we have an active 67-year-old female presenting with back and leg pain after a previous L4-5 fusion done about 6 years prior. She more recently developed the leg pain, but the back pain's been 3 out of 10 since her surgery, and at this point, she's exhausted conservative treatment measures. On the left, you can see a lateral x-ray of her lumbar spine showing her prior L4-5 posterior spinal fusion, adjacent level disease, and anterior listhesis of L3 on L4. In terms of her sagittal alignment, she has about 6 degrees of lordosis through L4 to S1 with an overall lumbar lordosis of about 18 and a pelvic incidence of 54, giving her a pelvic incidence lumbar lordosis mismatch of about 36. Her pelvic tilt and her sacral slope are shown here, represented by the triangles, with the blue triangle representing her sacral slope and the gray representing her pelvic tilt. On the right is a sagittal cut for MRI showing stenosis at L3, L4. She does appear to have less of a slip on the MRI cut compared to her upright x-rays, indicating this is an unstable degenerative spondy. In terms of her axial MRI, it showed stenosis and facet arthrosis and fluid. So question for the panelists is, what would you guys do for your operative plan for this patient?
Can I ask a question? So I'm just looking at your history. And it says leg pain recent, back pain 3 out of 10. So what's her major complaint coming to see you right now? Is it claudication, neurogenic, or is it 3 out of 10 back pain?
It's leg pain.
So
she's got pretty substantial claudication.
So it's a neurogenic issue, because
yep.
I mean, as it's presented right now, it's like, 3 out of 10. We can't do a whole lot with 3 out of 10 back pain. But if it's a neurogenic claudication issue, then obviously, then it brings into a surgical situation.
Yeah, she absolutely presents as fairly typical claudication.
Okay.
I guess my first question is, if you look at the MRI alone and then the x-rays, does that change your opinion, and does having her measurements in front of you change your opinion as well?
An axial CT or MRI might be helpful at that level.
It looks like most degenerative spondies. I didn't include it. It looks like most degenerative spondies. She's pretty darn tight at that level. She's got fluid within her facets, consistent with the mobility that you see on those upright films versus her. There's no surprises.
So I mean, she's
full-length film, or how about the EOS? See what overall alignment is.
Yeah, we don't have an EOS. I do have full-length films on her for brevity presented with these. There's no surprises. This is not a trick question.
You know, so 67 is reasonably young these days, and there's not a lot of anterior vascular calcification. So the reason I asked about, you know, an axial MRI is the question is whether indirect decompression via an anterior procedure, maybe with supplemental, you know, percutaneous posterior screws, as opposed to an open decompression, may be adequate. That's why I asked that question.
Yeah.
And Paul, the other thing, it doesn't look like she had an interbody fusion. Is that correct? They just did a
No, her original one did not have an interbody.
And she's got a flat back at best, if not a little kyphus there. So you've got to make up some lordosis ground with your indirect or direct decompression at 3-4. So, you know, this is begging for an interbody component to it. And as Scott is alluding to, in our place, we'd be looking to do this anteriorly with an A-lift because we think we can do our best carpentry, elevation, mobilization, indirect decompression through an A-lift if her vessels will hold that. But you certainly wouldn't want to get away with another insight to posterior pedicle screw fixation in this position. You wouldn't be doing her any favors, even with a nice decompression.
Hey, Paul.
And, you know,
Yeah.
go ahead, Rick.
Jens Chapman is asking if flexion extension x-rays are more important than even full-length films. What are your thoughts on flexion extension x-rays?
You know, I think if there's a pretty substantial difference between your supine MRI and your standing X-ray, I think that tells you a lot of what your instability is. So, I mean, I guess the question I have with that is, if she didn't move on Flex X, but you saw this X-ray, would you consider saying it's not unstable and decompress it alone?
That's a lot of slip. I mean,
Yeah.
that's more slip than I would be comfortable saying just do a decompression. Armin Kachetarian said, what about an X-lift? Can you get enough lordosis from an X-lift as you can from an A-lift to really, you know, create, you know, a little bit more sagittal balance?
Yes. Kayla, you want to show?
Sure. Okay, so here's our post-op x-rays. So we did a OLIF at 3-4 to improve her lumbar lordosis with an 18-degree cage, as well as a Smith-Peterson osteotomy, and revised her posterior fusion to extend it to L3. Overall, we're able to gain about 28 degrees of lumbar lordosis, moving her overall lumbar lordosis to 46, giving her a pelvic incidence lumbar lordosis mismatch of about 8. We also did decrease her pelvic tilt as well. And post-op, about 2 years now, she's doing much better.
Did you do the posterior osteotomy first, or did you do it after the anterior?
That's a really good question. I did her anterior first because I didn't want to do back, front, back. And I just the other day did the guy I normally would have to do 2 PSOs on because he had 60 degrees of mismatch. And I did him back, front, back with hyperlordotic cages, and I loved it. But it's just so painful.
Yeah.
So good, really good question. I mean, we got this lady where we needed to. If you look real closely at her X-rays, you can see there's a little divot where her cage cut into her inferior end plate of 3. So we probably didn't get every bit of what we wanted out of her, but you know, still obviously pretty good.
Did you do a direct decompression too, or just indirect?
Yeah, Smith feet, full Smith feet.
Okay. Because one of the problems with the hyperlordotic cages is the posterior intervertebral spread becomes really small. It's really a wedge. So you don't get the same kind of indirect decompression as you do with a more rectangular.
Yeah, so there's a question in the comments section during our journal club the other day about exactly that. And my response was there's sometimes competing goals. You can get either a lot of lordosis or a lot of indirect decompression, but it's hard to get both unless you put a just really massive cage. Then you worry about bone quality, and you sometimes have to, you always have to pick your battles in spine. But if you're here, we're looking for lordosis primarily, knowing that we can get decompression another way.
Right. What do you guys put in your cages, interbody cages now, Paul?
I use Infuse and Mastergraft.
Okay.
And Paul, what kind of graft is that? I mean, cage?
It's 18-degree cage.
No, but who makes it? What kind of?
That's Medtronic.
I don't see the post-op film. I don't know why I might
move your.
Never mind. I gotta minimize.
Or turn yourself on your head, Scott, then you'll be able to see.
Yeah.
This
sorry,
is
guys.
Jens. So one thing from my perspective is, was this a preordained failure? Meaning several of our old major icons of spine surgery have always told us, if you do a fusion, make sure that L4 is level to the ground. And this patient was right from the beginning pitched forwards. And a patient has some connective tissue disease, which you seem to have, and some degree of stenosis. This forward slipping of the next higher vertebra is literally a foregone conclusion, regardless of the unfavorable PI situation. So the question to the group is, should we, when we do fusions that involve L4 down towards the sacrum, really make sure that the sacral end plate is parallel to the horizon level, A, and B, do we actually need all these ratios and angles if we just follow simple old principles? And I think Izzy's mentors in Toronto were some of the mainstays of that level L4 principle.
Hey, Todd, what's the New York operation for this?
It's two different operations. Some guys would have done exactly this, but Frank Schwab or Hanjo would have done this from the back. You probably would have gotten up to T10. She would have had probably some SPOs, depending on how she corrected, and would have done it all posteriorly.
Including interbodies, they would have done T-lifts?
Yeah. Yes.
And Todd, you said from T10? Why did T10?
Oh no, I'm exaggerating.
Being
They
facetious.
would have gone as high as they had to go to get, the numbers right. I think this is a beautiful result. I don't think you can always get this result with this operation, though. This is a beautiful result.
Neil, what's the
I
super
think
jour in
the
LA?
key to this, Todd, I think the key to this is someone asked if you could do an X-lift. This is an O-lift, and I cut her ALL. I cut her ALL, 2/3 of the way across. And I think that's really the advantage of the anterior to psoas procedure is that you can get that really good anterior exposure and do your anterior release. I remember talking to Paul Anderson, my mentor, when I was really excited about these minimally invasive. He's like, hey, we've been doing that for years. We do these big shark bites, and we took out the entire annulus all the way around, all the way to the other side. This obviously is a bit sexier, but it's, it's not a new concept to be able to cut the ALL. We could just now do it through nearly an outpatient operation.
No, that's what
That's great.
when this anteriorly with an anterior inner body when I was doing these operations.
Yeah. All right, Kayla, can we move on to the next? I'm gonna do my talk, and then we'll show a couple other. You'll notice a theme. I'm gonna take. All right, my screen showing now.
Yes.
It is.
Yep. All right. So this is a talk that I've Jens will know from the time that I was his fellow now 12 years ago. That I've always been interested in spinopelvic. I've always been interested in revision surgery. I've always been interested in trying to not say we don't need to do fusions, but trying to do fusion better. And certainly learned a ton of things in my time out in Seattle. And we always said, hey, let's get more lordosis. And I think one of the things we figured out is finding the right amount of lordosis. The most important thing that happened to me was a ski talk in early 2014 that made looking at the pelvis make sense in a way that I hadn't had before. Essentially, what we're all going for is to be the Zen rocks, right? If you don't have the bottom Zen rock good, the rest of the Zen rocks aren't going to happen. But we know from EMG studies that you have essentially no firing of your quads, of your hip flexors, of your posterior musculature, if you are standing up straight with everything balanced. But you're essentially a crane that only works from a massive amount of energy being put into the system if you are unbalanced. And the pelvis is really sort of the keystone of that. The measurements are all based on
Dr. Kraemer, I just wanted to let you know the slides are not advancing. You're not in presentation mode. I don't know if you need to.
It says my screen sharing is.
Yeah, we can see it. You just have to go put your PowerPoint.
Yeah, we just see the title.
Are you there now?
Yeah, we're here, but you have to put your PowerPoint into presentation mode.
It's in presentation mode. Do you want to take over?
I don't think
I can do new share. Mine says I'm in presentation mode.
Your PowerPoint does because it.
Yeah.
Yeah, it's not advancing, Paul.
So,
Okay.
Maybe you can just advance them, Paul. Just
You want to just advance for me there?
I don't think I can advance it because you have control of the screen.
All right. Let me do one thing here. I'm gonna go to now. I'm gonna share my screen once again. What are you guys seeing?
nothing.
You.
We're gonna share your talk, Dr. Kraemer, and then
Okay.
you can take control. Okay.
Go ahead and do that.
Here we go. And we'll give you control. You should have control now. So just use your mouse there to
All
get
right. Now I got it. Okay. You guys see it? Now you're
Good.
seeing the Zen
That's
Rock.
great.
we got
Perfect.
your
All
rocks. Yep.
All right. So what you want to be is the Zen Rocks, not the crane that only works if there's a tremendous amount of energy being put into the system. So this is sort of the diagram that we've all seen a bunch of times and eyes glossed over, and it's all the information is there, but it's not necessarily super helpful. Everything's measured off standing films. The all standing X-rays should include femoral heads. You take your perpendicular from line across the sacral end plate. That gives you essentially the axis of the sacrum, then align to the center of the femoral heads. If they're not perfectly lined up, you estimate the point between them. A vertical tells you the pelvic tilt. A horizontal tells you the sacral slope. And here's the X-rays of the lady we just saw. That's why I had Kayla present her first. We'll use her as an example. Here are her femoral heads. Here's our line, and our perpendicular gives us the axis of the sacrum. Here, this angle is her pelvic incidence by definition. You can draw a line up traditionally from there, and then that angle is your sacral slope. The next angle is your pelvic tilt. This is your sacral slope. And right now, then you can make it even more confusing by drawing these lines, and that gets really confusing. Let's break it down for a second, because that is intrinsically confusing, and that's why the triangle method that I've been showing on that other one, I think, makes a little more sense. I'll prove to you that mathematically it's the same. You start with the same pelvic incidence. You draw your line up. Mathematically, that's the same thing as drawing a line down. So this angle is the same as this angle. That's just high school geometry. If you know pelvic incidence is your sacral slope and your pelvic tilt, then drawing your line across here is mathematically the same as having that. Then you just clean up all of the junk by making turning it into the big triangle. The big triangle is your pelvic incidence. The small triangle is your sacral slope. The anterior triangle is your pelvic tilt. So now you have all the same information demonstrated in front of you. And as we saw from this case presentation, you can visually see the change in the pelvic tilt decreasing and the sacral slope increasing. You can also visually estimate what is a large pelvic incidence. Here we have a small pelvic incidence. Here we have a very large pelvic incidence. Here we have sort of a medium one, right? So you can, without having to initially do all the measurements, this nomenclature helps you quickly understand that you have different pelvises. Here this is what, if you have negative sacral slope, that's what that looks like. Here you have somebody with a very large pelvic incidence, but a small pelvic tilt. Here you have very large pelvic incidence, but very large pelvic tilt. So it's a visually intuitive way of measuring, and I think better understanding, because when you understand the pelvis, then you understand, when you understand the nomenclature and understand what these things mean, you can then begin to apply them to what to do. Very quickly, the pelvic incidence is a fixed or very, very nearly fixed. There's some small changes that happen from sitting to standing, but for any one person, it's essentially a fixed angular measurement while standing from the femoral heads to the axis of the sacrum. That's essentially a counterbalance. Your spinal curvature is a counterbalance to that. So that defines your lumbar lordosis. Your pelvic tilt changes with time, depending on how you're standing, depending on how much you're compensating. And it's not a fixed value. It varies inversely with the sacral slope, and it's one of the ways in which patients compensate for not being able to give themselves the lordosis that they want and therefore find a way to get their shoulders in a within their cone of economy. Mismatch is something that's been defined by the International Spine Study Group and traditionally applied to the spinal deformity. And while I don't consider myself primarily a spinal deformity surgeon, you can't be a revision surgeon, which is what I consider myself primarily what I do. You can't be a revision surgeon without understanding deformity. Yes, there's some more and more complicated things about mismatch all the time, including advanced age, extremes of pelvic incidence, and some hyperlordotic upper lumbar segments that get confusing. And the lumbar distribution index is somebody else writing a paper of something that I've been trying to say for a while, which is get L4 to S1 right, and you're going to be okay. Get L4 to S1 wrong, and you're going to chase it all the way up the spine. So we're just going to step through quickly to look at a couple different examples. Pelvic incidence. Here's a really low pelvic incidence. Here's a mid-range pelvic incidence in two different situations, and here's a really high pelvic incidence. All right, so you see how the triangles and how they help you understand the size of the two triangles together is what tells you what pelvic incidence is. Here's mismatch. So same images but different numbers. So here, did I skip? I went for mismatch. Okay, so here's mismatch, and that is how much lordosis minus how much pelvic incidence. Essentially, so the 31 is the same number. She's got only 15 degrees of lordosis, mostly because L1, L2 is wrong on her. Here you go from our 18 to our 46. You can see how much more lordosis you have through here. And this person actually has 4 degrees of kyphosis over the expanse of her entire lumbar spine. And now here's lumbar distribution index, which is a little bit different. So that's a ratio of how much lordosis you have, whatever that may be, from L4 to S1 versus the entirety of the lumbar spine. And this is a lady with a minimally invasive T-lift who's actually somewhat kyphotic through that and has a lumbar distribution index of 0.1. You want it to be 0.5 to 0.8. And here's her post-op images realigning her. You can see how her triangles change. You can see her LDI is much more favorable. And here you can't really do the math because she's got no lordosis from anything times 0 is 0. So that's designed to, I can't advance now. Okay. So that gives you some of the detail on some of the statistics for those of us who don't look at them all the time. I also want to talk to pelvic tilt because I think more and more pelvic tilt is what I find myself looking at as a marker of success in lumbar fusion. We'll talk about a couple of studies that talk about that in a little bit more detail. But I think the best example of that is here. Here's a small pelvic tilt. Here's a large pelvic tilt. It's a small pelvic tilt, but it's still more than she wants because it's more than should be about 1/3. Here you see a pelvic tilt changing from about 1/3, 2/3 to 2/3, 1/3. A couple more words on pelvic tilt. This is a lady that I did really early in my career, and she had a pretty substantial coronal curve, which we made a lot better, but I made the mistake, the amateur deformity surgeon mistake of losing sight of the sagittal alignment while getting great coronal alignment. And while she's better, she's not great. She ends up moving to Florida, crapping out at the left level, having a big disc herniation, gets her fusion extended, has a non-union kyphosis here. And watch what, I guess the lesson is, watch what happens to her pelvic tilt over time. And then ultimately I did a PSO on her and straightened her back out. So watch the triangles, I think, show you how pelvic tilt changes over time. There's data to show that pelvic tilt is super important. A couple of smaller fusions, 18 patients that they just looked at who got better pelvic tilt and who didn't get better pelvic tilt. Well, if you got better pelvic tilt one way or another, all your scores were better. Both, not only we'll talk a lot about revision rates, but better back pain scores, better ODIs, better back pain scores. Small study, admittedly, but pretty strong p-values. This is a lady who I saw a number of years ago had to do a PSO on. Look at what happened to her numbers with a three-level T-lift, and they just took away a substantial amount of her lordosis by, I think fairly some blinders on while they were taking care of the individual problems rather than looking at the big picture, and ultimately came to me as a fairly classic flat back, wanting her next level fixed also. And it's okay, that's not the problem, lady. You got more bigger problems than that. Again, 32 patients with degen spondyes. The strongest correlation was for a decrease in pelvic tilt and improvement in VAS, which fits with my experience for sure. If their pelvic tilt decreases postoperatively, it means you gave them enough lordosis that they not only were standing up straight, but they had extra left over to spend to get their hips underneath them. And some of the studies I find the most interesting is just looking at the best versus worst patients. And here they looked at their worst patients all had an increase in their pelvic tilt. If you have an increase in your pelvic tilt, it means you took away lordosis and they have to stand by increasing the amount of compensation that they have to do. Here's a lady who essentially had a pelvic tilt problem. She had an old knot rod back in the 70s, and then it crapped out at that one level and then crapped out at another level beyond that. And essentially what she needs is just a pelvic tilt operation. She needs an L5 PSO and she needs her hips put back underneath her. So she essentially what she needed is a pelvic osteotomy, but all of her problem is pelvic tilt. And here she is post-op day 2, I think. So understanding pelvic tilt, understanding pelvic incidence helps you estimate the magnitude of the deformity, but understanding pelvic tilt helps you know where you have to get that correction. Here's a lady who I think they didn't quite recognize the magnitude of their deformity. She had a T10 to S1 PSF, which isn't the worst plan in the world. It's the rep's fault. They forgot to bring the rod benders that day. And here you have an underestimation of the total amount of deformity. And then again, a further underestimation, different surgeon, but different underestimation, leaving a really substantial amount of pelvic tilt still there and not changing. These numbers is 58, 50, and 47 is the T1 pelvic axis. So I think looking at the pelvis helps you realize that with her original numbers, with a very high pelvic tilt with no lordosis, there's a tremendous amount. You've got to get one osteotomy, just gets your hips underneath you. The second osteotomy gets your shoulders where you want. So your choices there are either some anterior column reconstructive work, as I was mentioning before, the back front back with the hyperlordotic O-lifts, or 2 PSOs, which is super painful. It might be even more painful than the back front back, but they're hiding deformity in their pelvis, and it's not just getting their shoulders where they belong. So how do we know these things? We know them based on a lot of data from the guys at the International Spine Study Group. Mismatch, plumb line, and pelvic tilt. I usually sort of think of 1/3 PI. We have more and more data in the last 5 to 7 years, and these are sort of the ones that we hang our hat on. We talked about these a couple days ago. The Rothenfluth study for sure. Min I referenced a little bit earlier. Barrett showed me that this is actually not technically correct to say they have a 10x risk of undergoing revision surgery for reasons he can talk to you about statistics. But high PILL mismatch definitely leads to substantially increased risks of revision surgery. If you were in the well-balanced group versus the poorly balanced group, is 24 versus I think it was 75% altogether. And if you get, even in short fusions, and these are all studies done on 1 and 2 level fusions, short fusions, we get consistently better revision rates, better back pain scores, and there's even one of them I think we're going to show here that has better leg pain scores. This is the Rothenfluth that we talked about on Friday, but for those of us who weren't on that talk, looking at cases where they followed them up about 49 months, so a fairly good amount of time. They had a control group, and they looked at what they called type A, which is mean you were well aligned. Over that time period, you had about a 25% chance of being revised versus 78.3 that were classified as type B, and that's where the odds ratio of 10.6, which again, Barrett tells us it's not exactly 10 times more, but and here's that same lady that we showed that I end up showing a lot. You can get it wrong with 1 to 2 level fusions and find yourself in disastrous situations. Here's a lady who had a very high pelvic incidence, had most of her lordosis up high rather than down low, had a single level fusion, had a add-on single level fusion for a massive disc herniation at L5S1, and then ultimately is in a flail type situation for as we talked about a little bit before, get L4 to S1 right, and you'll be okay. Get L4 to S1 wrong, especially with the high pelvic incidence, and you'll chase it all the way up the spine. This is the Zach Temple and Adam Cantor's study that we talked about a little bit about the revision rate from some T-lifts, all single level T-lifts, showing you that even a single level T-lift or a 1 to 2 level T-lift can turn into a disaster situation if you're not watching the numbers, and especially recognizing high pelvic incidence, high pelvic tilt as somebody who is at risk of turning into really a flail situation. This is one that's interesting because, again, showing that even the 1 to 2 level T-lifts, getting them better aligned, they had better scores in lower extremity pain as well. We've talked about VAS back and revision rates, but there's at least some evidence that leg pain matters as well. I don't think that's probably entirely true, quite honestly. I think that leg pain is related to your decompression, but back pain and revision rate is related to your balance. But low back pain while standing was most strongly correlated. Here's another study about compensation. If it's true for 1 levels, it's really, really true for 2 levels. Here's a 2-level spondy. Here's the biomechanics saying that 2-level spondies matter more. Here's the clinical stuff saying that if you got them into the good group, that they did better. If you didn't get them, degen spondies have more deformity cooked into them typically, and they have they need more correction, and anything that you see for a 1 level is more true for a 2nd level, and you know, if you don't get them corrected, it's not going to get there. There's more and more studies, and I'm not going to read you every single bit of this. There's more and more studies all the time. This is the review article that we talked about. Here are their conclusions from that review article about how important it is, the pooled analysis demonstrating that if you didn't get them right, you had a substantially higher chance of going on to adjacent level problems throughout that meta-analysis, subject, of course, to all the meta-analysis issues. So here's a couple more talking about what the other study we talked about the other day about the relative lumbar lordosis and getting it right from L4 to S1. When guys talk to me and say, hey, I don't need to know this stuff because I'm just a 1 and 2 level surgeon, I have 2 comments. One is, if you operate on L4 to S1, then you need to understand deformity principles. And the other is, I'm happy to argue with anybody about spinal pelvic alignment, but with the following condition: I'm going to stand with appropriate spinal pelvic alignment, and you got to stand with what you consider acceptable, even if it isn't. And we're going to have a really, really slow debate with me standing well and you standing how you got to stand. And I'm just going to talk really slow. We'll see how you do, right? In fact, when I give this talk to, I'll oftentimes pick on medical students or residents and make them stand up on stage, bending forward, compensating with their hips, compensating by extending their thoracic spine, doing all the stuff that we see our patients doing, and they get hurting real fast. There's more studies. We don't need to go through every single one of them, but there's more and more out there all the time, and I predict that there's going to be more and more. We've got to learn. Fusion's not going away, despite all the good work of Jack and Rick and all the guys about lumbar disc replacement. Fusion's not going away. We've got to learn to do it better. Here are my rules: aim for 5 degrees, try to get 9 degrees, tight window for low PI, wider window for high PI. Get L4 to S1 right. If you don't get L4 to S1 right, you got to be a hero at L3, or you'll chase it all the way up and down the spine. This is the age matching table that everybody should be able to refer back to. This is a quote that's actually kind of old now. It's from Shaffrey Ames and Brian John, and it's a slightly more eloquent way of what I think Izzy was saying the other day is everybody's a deformity surgeon. You're either creating deformity or fixing deformity. So this is a really, the reason I include this is it's a really routine case, and I don't think anybody looks at this and thinks anything besides, okay, you got a 1-level spondy with some fluid in the facets. You get her upright x-rays, you do your measurements, and all of a sudden you realize you might have something a little bit more complicated on your hands that maybe 2 steps away from T10 to pelvis PSO. Do we want to talk about this now? We want to jump right into questions. We want to talk about cases. How would you guys?
Paul, one thing I just want to mention, that was a great roundup. You hit all the high points, but there's one thing that I just want to emphasize. You mentioned getting the femoral heads on all the lateral x-rays. I've got to take that further. I want to see the standing films with as much of the femur as possible, because a lot of the times, and I've encountered this over and over again, some of these chronic fat backs, we're in Texas too, chronic flat backs have fixed flexion deformities of the hips due to psoas contraction. And you can do a beautiful spine operation, osteotomy, they come back and they're still pitched forward. And I've had to actually do anterior capsular releases and psoas tendon releases on these people to stand up straight. So don't forget to evaluate the hips. Make sure they still have enough extension through the hips before we go through all this.
Yeah, I look forward to the day where we all have EOSs everywhere, and that'll fix a lot of that problem. I agree completely that there's a million ways in which patients hide deformity. I always try to talk to them before I send them over for their full-length films and say, number one, don't give me your best behavior X-ray. Give me a real X-ray. I'll send your wife over there with you if we need to show them how you really stand, and not lock out your knees. And then whatever happens. Well, that's what we want to see. I don't want to see you compensating, and as to your point, Izzy, of compensating off screen essentially by flexing their knees and not appreciating their flexion contractions of their hips. Zach, you want to? I think you're up for the next case.
Okay. So this is an interesting case. Patient was a 68-year-old female who presented to our clinic with a history of prior L4-5 posterior spinal fusion. She presented with complaints and imaging consistent with adjacent segment stenosis at L3-4, which you can see on the MRI cuts on the right part of the screen. Interestingly, she did have evidence of a T11 compression fracture of unknown chronicity. As you can see from the lateral x-rays, she has a very large PI of 85 degrees. But interestingly, despite her low lordosis at L4S1 of only 12 degrees, she is fairly well balanced in terms of overall lumbar lordosis of 74 degrees, given her hyperlordosis of her upper lumbar spine, with L1 and L4 contributing 62 degrees of lordosis. So we performed hardware removal with her fused L4 to S1 segments and then decompressed at L3, L4. This worked well for 6 months, but then she began to have recurrence of her symptoms of L3-4 stenosis. Here are her post-decompression standing x-rays, which show an even greater lumbar lordosis now of 89 degrees. She has now been completely destabilized at L3-4 with listhesis and a progressive lordotic deformity of the upper lumbar spine. As you can see from the selected CT and MRI cuts, she has resultant stenosis at L3-4 with significant posterior bone loss as well. She remains symptomatic and interested in surgery. Can you guys hear me okay?
Yes.
Okay.
Yes.
Your microphone, your papers are near the microphone, which makes it hard to hear you.
Got you. Okay. On a side note, we're currently working on a study at Indiana Spine Group looking at exactly this question of decompressing above a prior fusion and risk factors for ultimate failure as defined by future reoperation. And we are finding a strong correlation with lordosis distribution index and rate of reoperation when decompressing above a prior fusion. In this patient's case, it isn't surprising that her decompression failed given her very poor LDI despite really no PI-LL mismatch. Regardless, this poses an interesting question of how best to address her pathology at L3-4 with posterior bone loss in the setting of an overall well-balanced spinopelvic alignment, albeit with a very high PI and a hypolordotic lower lumbar spine and a hyperlordosed upper lumbar spine. So I'll open it up to the panel here. How would you best, or how would you recommend treatment here?
Can I ask a question for Paul or the deformity guys? I mean, she might be overall well balanced, but there's a ton of lordosis and compensatory kyphosis in the thoracic. I mean, we always talk about rebuilding lumbar lordosis. Is this a circumstance where you may want to take away a little bit of lordosis when you reconstruct her? I've not ever heard of that in any of the meetings or in our conferences at TBI, but she just looks too lordotic in the lumbar spine.
The problem with that is you've got to make sure that the thoracic spine is going to reverse its compensation.
Exactly.
This is a very difficult case. This is probably the most complex thing when you're looking at the whole chain reaction up and down the entire spine, what's going to happen where. And we don't see what's going on at her cervical thoracic junction. I suspect she's got issues at the cervical thoracic junction as well. So you've got to really assess up and down. And I'd look at this and evaluate what her true functional level is and what she wants to achieve, and then try to rebuild the spine according to that. If she says, I just want to be pain-free, I'm going from my bedroom to my bathroom, then maybe we're just locking her in place where she is there. If she's saying she's got to stand taller, straighter, and her hips aren't working, then yeah, maybe she's a combination of PSOs and SPOs and multiple different anterior interbodies with fixation from the cervical thoracic junction all the way down.
You know, in my experience, if someone wants to say that they want to be pain-free, whether you're a degenerative or a deformity surgeon, that's not a person you're ever going to please.
Scott, I think you alluded to this. There are a couple of issues here. We're seeing back again a standalone posterolateral fusion in flat back. This patient is a high PI. She has no option other than hyperextend her spine to balance. Yeah. She has to hyperextend. That's her compensatory bad balancing. If you look at a thoracic spine to the compression fracture, she literally is hyperlordosed to lumbar spine, collapsing into a compression fraction of thoracic spine. This one, if anyone needs an EOS, this one needs one. I agree with Izzy, or cervical thoracic is probably decompensated too. So you create an amazing chain reaction. And yes, the only way is to bring her back to where she needs to be and take away that exaggerated lordosis. And one of the ways to do it is to do it through ligamentotaxis. You could do it through laterals. And I'm sorry, a laminectomy about that deformity was a bad choice. I'm going to openly say that. That's going to absolutely destroy this patient. I'm sorry if you guys did it. I say that to residents every day. Bad choice on hyperlordotic spine. It's going to kink. It basically kinked itself out. You can see it. So this needs multi-level laterals. That's the way we'd approach it. And you can reconstruct this, provided you have an EOS. You need an EOS going all the way up.
If you look at
a couple of things to for a little bit more history, guys. She is an amazingly functional, normal person. You would look at her and say she's you know, just a regular. You wouldn't notice anything different about her. She's very active. She does have a very short waist. She's a little annoyed that she has become very short-waisted as she's aged, but she really has isolated L3 pain.
If you look at her x-rays and you eliminate from L4 up, you look at 451 and the sacrum, that's essentially a tabletop right there. So if you're going to do something there, you've got to go all the way back to the bottom and try to rebuild that bottom. And then the other aspect, if you add that extra history, you say it's L3 pain, treat the L3 pain. Ignore the way the picture looks. Treat her pain and discomfort and do a one-level procedure on her at that point.
Yeah, so Izzy, that's essentially exactly what I did. She is a really functional person with L3 pain as proven by some selective nerve root blocks. And I said, listen, we can get super complicated by more lordosis at 5-1, hyperlordotic A-lift there, taking away some from where you're hyperlordotic at 2-3 and 3-4, and then bringing you up to T10 and spanning, or T9 and spanning that compression fracture. Or we can just say, hey, you're going to be short-waisted and let's take away the neurologic pain. And so Zach, show us what we did. Zach, can you go to the next one?
Trying to advance it here. There we go. Yeah, so what we chose to do was a two-level OLIF at L2-3 and at L3-4. We decided not to pursue TLIF at these levels, given the extreme hyperlordosis and the fact that it would be very difficult to access the disc spaces through a posterior approach, given how closed down the posterior disc spaces were at these levels. We then went posterior to back up our OLIF with screws. A direct posterior decompression was not performed. As you can see from the x-rays, we did not significantly alter her sagittal alignment through the operative levels, and she remained well balanced with a PI-LL of only 1 degree. The OLIF provided excellent stabilization through the interbody cages, as well as with posterior instrumentation at these two adjacent hyperlordotic levels. And as of our most recent follow-up, the patient is doing extremely well without any complaints.
Symptom-specific surgery. Treat the patient, not the x-ray.
Yeah, it's a great case to illustrate the degen versus deformity arguments, one way or the other.
No, that's great. Did the posterior screws, did you do them open or percutaneous?
I did them open.
Open? Okay.
And I did decompress. Zach, I did decompress her L3 directly because, like we were talking about before, you got somewhat of a challenge between lordosis. You know, years ago, I might have done a T-lift there. Man, that would have been a hard T-lift. That was a really deep hole. Trying to maintain that amount of lordosis and not accidentally flat backing her. I mean, that would have been really difficult revision T-lift. But you can just sort of hold her where she is and be okay. She healed up fine. Her neck was not fine. She didn't have any deformity. We actually did her neck first because she's myelopathic. But she had a ugly neck, but not from a deformity standpoint. All right, Chris.
Paul, you're muted.
I don't think our
There you go.
fellow has. Thanks, Rick. I don't think our fellow has made it back. He's having in the midst of a family emergency, unfortunately. So I'm going to present his cases. Can you give me control, Megan? Can you give me control?
You have control.
All right. So these are, I'm going to present two cases that we did two different things. This is a 62-year-old, no previous surgery, again, fairly classic, 3-4 degenerative spondylolisthesis, really bad level at 4-5. I think most of us look at this single level, as a single level straightforward operation where you're going to get pretty consistent results. It looks a little different when you see her standing x-rays, and I think her MRI and her x-ray makes you think two sort of different things. Let's go through all her measurements. She's got a 60-degree pelvic incidence, 27 slope, 33, so too much sacral slope. I'm sorry, too much pelvic tilt. She's got almost no lordosis, only about 7 degrees from 3 to 5. She's got what's probably almost certainly a transitional segment, not going to move much at her 4-5 segment. And she's got 25 degrees of total lordosis, so 60 on 25. Anybody want to throw out a quick opinion? I'll tell you what, I did this about 4.5, maybe 5 years ago now. And what I did was the hero 2-level T-lift, pulling out every trick in the book to get as much lordosis as possible. I was aiming for 30 degrees of lordosis restoration. I got 30 degrees actually to the number, so I'm happy with that. But look at what happened with her overall lordosis. I learned two things from this case. One is to appreciate hyperlordosis of non-involved discs. Look at her 2-3 segment. Yes, I know that here I'm measuring to the top of 2, but L1's about the same up here. So if you add 30 to her 25, I should have gotten 55 degrees, but I gave away some at de-stressing her L2, L3, and L1, L2 discs. That's good. You don't want to have stress on those discs, but even pulling out every trick in the book of how to do a hyperlordotic T-lift, it was still kind of barely enough. I remember I did this with one of our visiting resident who I guess must be in practice now. He went to Beaumont and did a spine fellowship and did a great job. But I walked out of this case just exhausted and saying, I gotta find a different way to do this. And then about 2 years later, this is one of the instrument techs moms who's got a somewhat similar X-ray. She's got two level disease, really tight. I think this is 4-5, but 3-4 looks nearly as bad. She's got claudication. She's got back and bilateral lower extremity pain. You do her measurements, and she's actually a little bit more favorable. She's only got a 54-degree PI versus the 60 on the other lady. She still has almost nothing across her L4 to S1, and this was honestly a easy, kind of boring case where I bailed on the Smith-Pete at 3-4 because I didn't need to, because we got all of it through releasing the ALL and OLIF. So some of this is pulled from my rah-rah OLIF talk, but it's just become such a useful tool in hyperlordosing. I worked so much less hard on this case. Lady left the hospital in the same amount of time for sure. This was I think more consistent and less chance of the injuring the end plates, losing some of your correction, trying really hard to make something move that ultimately doesn't move. So I found this one to be substantially easier than the previous case.
Paul, if you had not released the ALL, you don't think you would have got it? Did you feel you had to release the ALL on that last case?
The problem with that is you don't know until you get them posterior, and then you can't do anything about it. I've certainly seen that where you say, I think we're gonna be okay. That's my Neil. I know you're a big fan of TransPsoas. I know you've migrated a little bit, but
I don't. I only do OLIF small for the last 8 years. And you probably the only reason I bring it up is we totally stopped releasing the ALL probably 6 years ago. You don't need it. That's why I brought that up. I think next time go there without releasing the ALL, you'll still get the same ligamentotaxis and the correction. Give it a try.
Yeah, I mean, I've had some trouble with that of either not getting the correction or damaging end plates and then having that divot in the front. So I've tried releasing the ALL. I've tried pie crusting it. I've tried just sort of cutting it halfway. Just the other day we were doing one for True Deformity, and I think the whole room heard the ALL tear. So it's I guess my problem with that is you don't know if you're okay until you've gone from front to back, and then are you going to go back again to try to eke out a little bit more and then go back again to close it down? So, okay. But interesting. Obviously, you've got a ton of experience.
Give it a try.
Other questions or comments on some of that? I haven't checked the chats. If there are any questions that come out of the chat.
So Paul, one of the questions in the chat was, if you do a bilateral TLIF as opposed to a unilateral TLIF, can you get better correction?
So on this one that I did, I put it's a unilateral implant, but a bilateral discectomy. When I said I used every trick in the book, that's one of the tricks, right? Is to do bilateral approaches, whether you put in 2 implants or 1 implant. I'm not sure is what's going to determine things, but certainly bilateral approach for those of us who are ortho, the analogy to total knee with TLIF, I think, is pretty substantial. If you want to get the knee to move, you do more releases. You don't put in an oblique implant, you don't put in an expandable implant, you release the knee and the knee will move. If you're trying to make the spine move, release the spine will move. And that's one of the tricks, is to go bilateral. Again, I feel like I maxed out. I spent a lot of time doing this, maxing out all my TLIF techniques, and now OLIF is like my favorite case.
I mean, there's no question you get much more lordosis with a lateral approach, OLIF or TransPsoas. You definitely get it. The bigger question is really, do you need to release the ALL? With a TLIF, you get about 5 to 7 degrees. You do an osteotomy in the back on both sides, you'll get 15 degrees. I think that's just a question of what you need and how much more you need. And you showed
I've had 2 recently that I did exactly that. Did a 2 or 3 level 2 or 3 level T lift for somebody with, that I thought I could eke out 7 degrees at a couple different levels they needed for decompression. If they have bad bone, especially with titanium implants, if you damage the inner body at all, you can lose it all if you stop at L5, because L5 pedicles are pretty large. You don't fill the pedicle entirely. They sort of pull through. And both of those I had to revise with hyperlordotic A-lifts and bring them to the pelvis. So I am at my low point in my T-lift enthusiasm, which will give Rick a chuckle because he and I have argued about T-lift versus PSF for years. But I didn't go your way, Rick. I went even farther the other way. Now everybody's an O-lift.
I think it's true with any interbody, right? If you don't preserve the end plate, you basically wasted an interbody. It doesn't matter what technique you use, whether it be
I'll give a quick
O-lift, laterals.
I'll give a quick plug for my a quick plug for my Instagram account. It's Instagram @Complex Spine Consult, where I show a lot of interesting cases of things like this in Instagram format. And what I have on there recently is exactly that lady that fine on the table, perfectly balanced on the table, lost a little lordosis on her standing post-op films, was just shit show by the time I saw her at 3 weeks. And we had to revise her with an hyperlordotic O-lift at 5, or hyperlordotic A-lift at 5.1, just to make up for the fact that 4.5 ended up collapsing so much.
Oh, that was great. I mean, the whole thing with last Friday and now with all these cases. Now, I have a question for you. Do you have an easy way of showing us how to draw those triangles? Because I really like that. I like them much better than the complicated.
Yeah. No, hey, listen, I'm working with Kern Singh in his journal to put this out there. It's just not easy it's not really a study, right? Like it's not different. It's the same math. I can go, if you want to go through it, I'll blaze through it again for you real quick. It's the, or I can make the talk available. If you go back to the talk from SSF, I click through, albeit fairly quickly, all the lines on the triangles. So I've been doing it that way for 4 years. And honestly, it started because I think I messed up how to draw them correctly and suddenly realized, okay, it's actually kind of easier. It's the other talk, Megan, if you can go to, if you can go to the beginning of the other talk. We still have Megan? Yeah, here we go. There, perfect. So here's the confusing stuff. So there's the confusing stuff. Here is the same axis of the sacrum. Draw your line across the top of the sacral end plate, perpendicular, line to the middle of the two of them. This is your pelvic incidence. That part doesn't change. Instead of drawing the line up, you draw the line down. Mathematically, the same thing, right? That's high school geometry. Then you draw in your horizontal from that same point. Again, that if we know that this whole thing is your pelvic incidence and this is your sacral slope, your pelvic tilt, then the only thing left is your sacral slope. You can do this like I do and on PowerPoint and convince yourself that this triangle lines up perfectly with this triangle. It's the same thing. You're just turning it 90 degrees. So the math works. And then you just clean up all the ugly stuff. And here you are with, with the two different triangles. Honestly, I do this all in PowerPoint. You just make a right triangle and I do my measurements on the software, import the image into here, and then just line up with my green lines. And it gives you the visual. It doesn't change your numbers. It doesn't change any of the math. It just makes it, I think, a more visually intuitive way of watching pelvic tilt decrease or pelvic tilt change over time as we see. This one, I guess, shows how a small triangle versus a big triangle as far as your pelvic incidence, right? Big triangles, be super worried because it's way easier to mess up a high pelvic incidence case than a low pelvic incidence case. And this is the one that shows how that same pelvic incidence same pelvic tilt changes over time based on her overall standing balance. And then this is one of my favorites, just to show how bad, like the pelvic tilt tells you everything you need to know about why this lady is crapping out in a short period of time. And you know, unfortunately for this lady, she's T10 pelvis PSO. But it tells you all the things you need to know. It tells you what her operation needs to be. It's really it's a pelvic osteotomy. And then on this one, it's just, I have a couple of these where, you know, the answer from the outset is either the answer from the outset is 60 degrees of correction. And there are two ways to get 60 degrees of correction. One is multiple hyperlordotic OLIF with, in my opinion, take it down the ALL. Neil would disagree, but the same concept. Or 2 PSOs, which, man, I hate 2 PSOs.
No, Paul, those triangles are a great idea. Nice job.
No,
Strong work,
great.
Paul.
Thank you, Paul. Thank you, Indy,
yeah,
guys.
thank you. And
Yes,
Paul,
thanks everybody.
Yeah,
It's
you
9 o'clock
reemphasized-
on the East Coast. Jens, Rick, and Jack, thank you so much. It's been a fabulous hour.
Thank you, guys.
Hey, it was great.
Thank you.
Everybody
Thank you,
take
guys.
care.
Thank you.
Thanks, guys.
Good night.
Thank you. Have a good one.